All right. All right. Hello, everyone. Thanks for attending our webinar, IR Residency Applications Program Director Perspective. It's brought to you by the Society of Interventional Radiologists, Medical Student Council, Education and Research Committee. My name is Rebecca Lee. I'm an MS3 at Florida International University, Herbert Wertheim College of Medicine.
And my name is Mohammed Noor, a fourth-year medical student also at FIU and studying Miami, Florida with Rebecca.
Yep, and we will be your co-coordinators for this webinar. So as many of you know, application season is on us, and it can be a very stress-inducing time. So we're really lucky tonight to have 4 program directors take time out of their busy schedules to speak to us and to shed some life-saving advice about the application process and how to be a competitive IR applicant. So we have an agenda for the night. So first we're going to have our program director panel introductions. Then we'll have a brief summary of the new training pathways. Then we'll be going to the Q&A section. We have some frequently asked questions for the panel, including questions regarding their programs, questions regarding the competitive IR applicant, and questions regarding personal statements and letters of recommendation. We also have a section for audience submitted questions for the panel.
Okay, as far as ground rules are concerned, firstly, we will mute all but the panelists' mics throughout the webinar to minimize background noise. Please type into the chat box if you have any questions or comments. As I will further go into later, please select my name, Mohammed Noor, from the chat drop-down menu, and I will announce your questions or comments to the panelists. Secondly, everything that is discussed during this webinar will be recorded. If there is any part of the webinar that is inappropriate or irrelevant to the discussion, it will be removed from the webinar before it is publicly posted. Please, and again, please send any questions directly to me by selecting my name. This is especially important during the Q&A session at the end. I will read and announce your questions to the PD panelists, and all questions and comments will remain anonymous. Please refrain from asking questions at the beginning, since it may be covered during the first part of the webinar. Thank you all kindly for your cooperation. Next slide.
Yep. So,
okay, now to introduce our panelists. First, we have Dr. Kaja on the line.
Hey guys, thanks for having me tonight, and thanks for setting this up.
Absolutely, Dr. Kaja. Sorry, my slides are a little slower to show up on the screen. So Dr. Kaja is a vascular and interventional radiologist in Ann Arbor, Michigan, and is affiliated with the University of Michigan Hospitals and Health Centers, as well as the VA Ann Arbor Health Care System. He is currently an assistant professor in radiology at the University of Michigan, where he is the IR Residency Program Director and also an associate program director of the Diagnostic Radiology Program. He received his medical degree and MBA from Indiana University School of Medicine, completed his radiology residency at University of Virginia Hospitals, and completed his vascular and interventional radiology fellowship at UVA as a VIR clinical pathway trainee. Dr. Kaja specializes in aortic disease and the management of complex venous and peripheral arterial disease. He has been involved in research with a primary focus on the endovascular management of aortic disease, specifically aortic dissections, aneurysms, and endoleaks, vascular complications of solid organ transplantations, and complex venous diseases and their management. So thank you, Dr. Kaja, for being a panelist on this webinar.
Thank you.
okay. Awesome. Next on the line, we have Dr. Prang Patel. So Dr. Prang Patel is a vascular interventional radiologist serving as the program director for the Vascular Interventional Radiology Fellowship and IR Residency at the Medical College of Wisconsin. He was also the chair of the SIR-PQI Workgroup Committee from 2011 to 2014 and has given over 120 lectures on a variety of topics involving anything from getting started in IR teaching to lecturing on the principles of lower extremity vascular disease. He is currently on the SIR Executive Council as a graduate medical counselor and is part of the IR advisory group to the ACGME. He received his medical degree at Loyola University Stritch School of Medicine, completed radiology residency at Loyola University Medical Center, and completed his Vascular and Interventional Radiology Fellowship at the Miami Cardiac and Vascular Institute. Since 2013, Dr. Patel has held the honor of being voted onto the Best Doctors in America list. Welcome, Dr. Patel.
Thank you.
Okay, next we have Dr. Paul Rishon with us. Dr. Paul Rishon is a vascular and interventional radiologist in Aurora, Colorado, and is affiliated with the University of Colorado Hospitals, Children's Hospital of Colorado, and Memorial Hospital. He is currently an associate professor in radiology at the University of Colorado, where he is also associate fellowship program director and director of non-invasive imaging. He received his medical degree from LSU School of Medicine, completed his radiology residency at Case Western, and completed his vascular and interventional radiology fellowship at the Miami Cardiac and Vascular Institute. Dr. Rishon specializes in minimally invasive treatment of peripheral arterial disease, aortic aneurysms, aortic dissections, primary and metastatic liver cancer, venous insufficiency, vascular malformations, and thromboembolic venous disease. He has been involved in over 30 publications involving endovascular therapy. Thank you, Dr. Rishon, for being with us.
Thank you very much.
And last but not least, we have Dr. Sabri joining us. Dr. Sabri, Sahar Sabri, is a vascular interventional radiologist in Charlottesville, Virginia, and is affiliated with the University of Virginia Medical Center. He received his medical degree from the University of Jordan Faculty of Medicine, completed radiology residency at the University of Iowa's Hospitals and Clinic, and completed his fellowship training in vascular interventional radiology at the University of Virginia. Dr. Sabri specializes in minimally invasive treatment of liver and kidney tumors, uterine fibroid embolization, thoracic and abdominal aortic disease, among others. He has been involved in over 30 publications and clinical trials involving endovascular therapy. Welcome, Dr. Sabri.
Thank you.
So, as many of you may know, IR is in a state of transition, having recently become a new specialty with a direct pathway. It's a growing field, and there are many pathways that a medical student can undertake on the journey to becoming an interventional radiologist. We've included a table of different pathways, and we're going to have Dr. Patel briefly discuss these different pathways for us.
Thanks, Rebecca. So by way of review, hopefully most of the attendees on the webinar have seen a slide similar to this. I believe this was came from the RFS website, and it is accurate, and there have been variations of this on other lectures as well as the ACGME website. But for sake of review and to set the tone for questions that may come, I wanted to run through this really quickly. There are 4 columns here. The traditional pathway, if we start from there and then move on to the right, is the way our current fellows have progressed through their training. They've all completed a year of clinical training in some form, and then have done 4 years of traditional diagnostic radiology residency. So for example, for myself, I think for most of us, aside from Minaj, we went from medical school and had to commit to 4 years of diagnostic training before we could get to the goal, which was ultimately interventional radiology fellowship training, which is what we ultimately wanted to do as a career. Thankfully now with the IR residency, there's a new route to go about this. But in any event, 4 years of radiology training, followed by your clinical year of training, was then followed by 1 year fellowship. So 1, 4, and 1, total of 6 years of training, has now evolved into the new IR residency. It used to be referred to as the IR-DR pathway or the direct pathway. The nomenclature now is the interventional radiology residency, and completion of this residency allows you to sit for the IR-DR board certification. It still requires a year of clinical training to begin, but then you do 5 years of training to follow, so 1 plus 5, which is a total of 6. What's maybe not exactly accurate in the integrated IR residency tab is that it's the 5 years is essentially 3 years of DR training and 2 years of IR training. But that's not to say that the first 3 years of DR training cannot have IR or IR-related rotations within it, and that the final 2 years of IR focus training cannot have some diagnostic training in it. But it's loosely structured such that you have a total of 3 years of DR training and a total of 2 years of IR training followed by that clinical year. It still consists of 6 years of total training, but much more focused on interventional radiology and interventional radiology-related topics to better train trainees to handle the clinical requirements that it takes to practice a meaningful IR practice or in a meaningful IR career. The third column represents the independent IR residency, which you may hear a little bit more about today. And I think many of you might be interested because for some of you, matching into a diagnostic radiology residency may be what ends up happening. And so there is still a route to gain IR residency certification or training, and this is through the independent IR residency. Hopefully you match into a DR residency that has an approved ESIR or early specialization in interventional radiology track, and that allows you to complete or satisfies that the program can provide 12 months of IR or IR-related rotations during your 4 years of traditional diagnostic radiology training. And if you successfully complete that, then it allows you to be eligible for advanced placement into essentially the second year of the independent IR residency. So then again, you are 1, 4, and 1, but 1 year of the 4 years of diagnostic radiology training consists of IR focus, and then your second IR year of training would essentially be like an IR fellowship year, and it still is 6 years of training to get to the end goal of being IR or be eligible for IR certification. The final pathway is for those candidates who match into a DR residency that does not have an ESIR track, or for a candidate who does not complete an ESIR track, but still determines that they want to do IR for their career. Ultimately, what the ACGME has said is that IR is its own specialty and has distinct qualities that no other specialty has. And to be able to gain that, you need at least 2 years of focused IR training. So if you didn't get any of that focused training in your first 4 years through ESIR, or say going through an IR residency track, then you need 2 years of focused IR training, IR and IR-related type topics, followed from your 4-year residency and the 1 year of clinical year. This is the only track that will require you to take an additional year of training, a total of 7 years to complete, but still allows you to gain IR-DR certification if you follow that route. So a lot to follow, but there are many ways, I think, is the ultimate point of this. And I don't want you to get bogged down in you know, I think the table actually explains it quite nicely, but there are, I think the key message, and we'll see what the other program directors feel, but there's more than one route to get to ultimate interventional radiology training. The IR residency obviously is the most direct route, I would say, and guarantees you a spot, but there are other routes that may be suitable for you too. And I think today we'll answer a lot of questions that many of you may have regarding how to go about this application cycle.
Alrighty, thank you, Dr. Patel, for that summary. Okay, if none of the other, do any of the other PDs have anything to say about, or anything to add?
No. I think that was really well explained for a complex table.
Okay, well, thank you, Dr. Patel, for that summary. Now we will begin the Q&A portion of this webinar. We have designed a set of questions which we believe will provide grounds for continuing discussion. To begin, we have questions pertaining to the PD's program. So the first question we have is, please tell us more about what the IR residency is like at your respective institutions. Do you offer the integrated pathway, ESIR, or both? So Dr. Patel, if you can please start.
Sure, I can start off. I didn't know which order you want to go in. So as far as what we offer, I'm at the Medical College of Wisconsin, Milwaukee, Wisconsin. We have an accredited integrated pathway. We are also approved for the early specialization in IR, so our diagnostic radiology program has approval for that track as well. So we do offer both and plan to offer both, and then we're in the process of completing our independent application this week. So not that that's immediately relevant, but we should be able to offer at least these two and anticipate all 3 pathways for trainees coming to our institution. As far as what our IR residency is like, this is going to be our first match year, so it's hard to specifically comment on it. I think probably SAR might be the one to give the most commentary about what his IR residency is like, because it will be similar to what he's currently offering, or what they're currently offering. But we know that our IR fellowship is quite busy. The DR program has many, I think, benefits or attributes to complement our IR residency, and so we feel pretty comfortable with regards to the prospect of our 5-year IR residency program. But I'm happy to take specific questions as far as insights as to what our IR residency may offer as far as electives and otherwise, but I can't tell. I guess I can't give you too much more detail than that right now.
Okay, perfect. Thank you.
I'd be happy to go next. This is Minhaj from University of Michigan in Ann Arbor. We also have an accredited integrated pathway. We did participate in the match last year and matched 3 residents and have backfilled a few positions. We currently have 7 residents in the program who are from PGY 2 through PGY 5. And so we adopted the clinical pathway and converted to the IR residency. We have 3 positions that will be in the match every year, and then we will be applying for the independent pathway as well and with ESIR, but have not been approved as of yet. In terms of the program of our residency, I think one thing that's special is that we have a approved and linked prelim surgery year here at University of Michigan, and everybody who will come through our IR residency will go through the surgical prelim year here, which is a top 3 program, and they have sort of accommodated our rotation schedule for the prelim year and given 4 or 5 months that we requested. So I think that that's really a benefit, and I think many of the other programs, I know UVA has it as well as Vanderbilt, so I think that that's a really good plus.
Okay. Paul Rashan, University of Colorado. In terms of our IR residency, again, as Dr. Patel said, this will be our first year going through the match. We will be selecting 2, or going into the match for 2 spots. We have an approved integrated pathway. We are applying for the ESIR as well as the future independent pathway. Just as most of the programs will be offering, our electives will pretty much go hand in hand with our collaboration with different specialties such as vascular surgery, vascular medicine, and also transplant. So we look to offer that for all of our trainees in the program. One thing that we also have, a lot of our diagnostic residents are in the past have been interested in IR, so we have about 3 on average in each year. So what we also plan on doing is hopefully having a spot where we can transition one of our diagnostic residents at the end of their, or at least choose them at the end of their 2nd year to transition into the IR residency. So hopefully in the future we'll have 3.
So similar, we have the integrated residency. We'll be applying for the independent. We applied for ASIR. We should be getting it. But I would say most programs you're going to be talking to are going to be offering all 3. I think almost every program that's integrated will have ESIR as an option. Just want to clarify something. I hear that a lot from students, which is, coming in, it's like, I want to do the ESIR pathway. You cannot choose ESIR from med school. The decision for ESIR happens during your DR residency. So you have to match in DR first without knowing you're going to be in ESIR or not. And then there's a selection process that happens sometime in your residency, and most programs will do it after the 1st year or after the 2nd year of your DR residency, Diagnostic Radiology residency. And then they'll choose who will be in their ESIR pathway. So that's something that is important for students to know, that you cannot choose to go into ESIR out of med school. You have to wait and see. So your options are either going into an integrated IR residency or going into a DR residency with the hopes that you will compete to get into ESIR with the other classmates that you have to get in there. So that's something that needs to be clear. Now, one of the options that you can potentially transfer into an integrated spot later on, if a position opens, like University of Colorado, we're talking potentially adding some options or some positions. For us, we have approval for 3 positions, but we're going to fill 2 positions. It's funding related. We may decide to fill 3, and maybe down the road you can transfer somebody if you secure funding to do it. And you'll see several other programs have that. They may have more positions approved, but they may not enter all of them into the match. We also have similarly a categorical position where you have a prelim surgery attached to it.
Okay, sounds good. Thank you to all. For our next question, how many applications do you receive? How does that compare to the number of spots available at your institution? For this question, we can go in the order of Dr. Rishon, Dr. Sabri, Dr. Patel, then Dr. Kaja.
Okay. So we really don't know how many applications we'll receive because this is our first year going to the match. But I can maybe extrapolate from our fellowship applications. Currently, we have 4 spots in fellowship, and we receive over 125 applications. One thing that I can note that on average for our diagnostic program, which we'll do for the interventional radiology residency, we'll probably interview anywhere from 10 to 12 applicants per position. So anywhere between 20 to 24 interviews for our integrated spots this year. I think that's pretty average for across the nation. Of course, we want to make sure that we interview as many people as possible, since this is one of the, only the second year that we're going through the interview process for the integrated pathway. And we know that there will be many applicants. It will be a really competitive process. That's why throughout SIR, Student Resident Committee, and throughout ACGME and the Resident and RRC, we've been trying to get as many programs accredited in preparation for this application cycle. So as Dr. Parag may mention, we've made leaps and bounds from last year, so hopefully we can accommodate as many applicants as possible. But as he's also said, there are many pathways to interventional radiology, and we want to make sure that everyone who has a sincere interest will get there through different pathways.
This is Sahar Sabri. So at UVA, we had a clinical pathway, so we've, which was similar to what the integrated pathway will be. So over the years, we'll have a good idea about the numbers. We have 10 positions per year in diagnostic radiology, 2 of them more for IR, so 8 and 2. So in general, we reach somewhere, get somewhere between 700 and 800 applications. And of these, usually somewhere around 250 or so are for IR, for 2 positions. And usually the application is around 10 to 12, as PJ mentioned, per position. So the thing is, the ones who apply to IR, not everyone is truly interested in IR, so it's hard to kind of get a good gauge of what it is. But the numbers last year were around 240, 250 applicants for 2 positions.
This is Parag Patel. I want to add, so we have two positions available in our IR integrated residency program, so 2 per year. We will accept applications in 2 weeks, September 15th, so we'll get an idea then. I can't tell you exactly what the numbers are. I think many of us have been trying to guess the number of applicants that there might be for the potential number of positions. I don't have the exact number of positions available because some people are matching not just advanced positions and haven't clearly posted how many positions they have versus categorical versus advanced years. But the estimate is somewhere in the range of about 100 spots that will be available in the match, give or take, spread across 40-some programs. And last year, there were 15 spots in the 2016 match. Those applicants did not hear about the availability of an IR match until the interview season had started, and the programs, the 6 or 7 programs that participated, did offer a total of 15 spots. There were approximately 135 applicants that at least ranked IR residency spots. Doesn't mean that they all, that doesn't mean that they didn't do something else like DR with an ESIR pathway, but we have that kind of data to guide us a little bit. I think the best estimates have been anywhere between 10 to 20 applicants per spot. We're planning on, for our 4 spots of fellows that we have a year, we get between 150 and 160, 70 applicants. And we're going to plan to interview this year for our IR residency roughly 10 to 12 per applicant. Probably more than that, actually. We have already set aside 50 potential interview slots for IR DRs or those that might be interested in an ESIR through the DR residency. So, and that's certainly more than 10 to 1, but because we have 6 DR residency slots, there's an anticipation that there'll be some interest there through the ESIR. But I think Sahar's point is an important one, and I'll emphasize it because I think it's worth reiterating. You can match into any of our DR programs that offers ESIR, but you do not automatically get guaranteed positioning within an ESIR track. All programs were required to submit their evaluation and selection process for matched residents into the ESIR program. That is to say, you match into a DR residency, and sometime after your first or second year is usually what most programs decided. After you've done some meaningful time potentially in the residency and in IR, then you can submit your decision to be considered for the ESIR, and there's a selection process. And sometimes it's as benign as just declaring your interest, submitting your CV, and having maybe a quick visit with the DR and IR program directors, maybe a brief interview or discussion, and they select, 1 or 2 or 3 or potentially everyone that applies for the ESIR if they're appropriate. But there is the ability for the program directors to decide that the resident is not a good fit for ESIR, and that's not up to me to decide. That's up to each individual program director. So there's not necessarily a guarantee, but I think if you're a resident in good standing and you have a definite interest in IR, I find that ESIR will probably be a pathway that you'd be eligible for.
So this is Minhaj from Michigan. We did, like Parag mentioned, we were one of the programs who went into the match last year, and we interviewed over 250 applicants who selected IR on the SIR-RFS application. And so at that point, it was the clinical pathway. And at mid-season, as he mentioned, it was converted to the IR residency and ended up interviewing a total of 45 residents or so, medical students last year. And so again, same within that 10 to 15 per spot and for 3 spots. So we interviewed 45 approximately and plan to do the same this year as well.
Okay, thank you. Our next question set is regarding the competitive IR applicant. So the first question in this set is, what are the primary qualities that you look for in an applicant? For this question, we can rotate with Dr. Kaja, Dr. Patel, Dr. Sabri, then Dr. Rishon.
Thank you. So I think there are a lot of things that make a candidate a strong applicant. There's not really one thing on your application, and I think that is what's important for all the programs, and I think everybody here agrees with that. We're looking for a complete application. That involves good grades, good board scores, but also strong involvement in IR and a continued dedication to IR over multiple years of medical school. It is IR or radiology, since this is a new program. I would say being involved with research and doing rotations on IR, and then of course involvement in the SIR, Medical Student Council, AMA, and interest groups. All of those things make very strong candidates, and I think together as a package help us determine who would be a good fit for each program. I don't think any one thing, though, is something that any of us would key in on. Unfortunately, everyone sort of looks at the board scores and worries about their board scores, but I think having good grades and good rotations and good letters of recommendation together make you a strong candidate.
Yeah, I agree with you, Minhaj. I don't think that's, and this is maybe hard for the attendees in the webinar to key in on because it's not pinpointing exactly what they need per se. But I think in a way you can take this as a good thing. I think what we're looking for is the all-around good candidate, and we're not going to key in on just one single number or one single, research paper that you did in IR focused. Yeah, I think the thing for me as a program director, and I've been a program director for my fellowship here, involved in it in the last 8 years, is that as a resident applicant, you have a lot more opportunity from medical school through your first few years of residency to declare or demonstrate an interest in interventional radiology. When I go back to when I was a medical student, I didn't even know about interventional radiology until my 3rd year of medical school. Now it's a lot harder these days because there's been a much more concerted effort with IR interest groups and IR symposiums, and the RFS and Med Student Council has gathered so much momentum and has been doing a phenomenal job with getting the word out. So I think a lot more medical students are aware of it, but there are still going to be those applicants who have a lot of potential to be a phenomenal IR resident who maybe just didn't come about IR residency because their local medical school didn't have an interest group or didn't have exposure to this until sometime into their clerkship years. And at that point, if you haven't done IR research, or to me, IR research is great if you have that, but not every institution has it. So interest in research or the ability to demonstrate it in a different area, maybe it's in surgery or one of the other specialties that we collaborate with. Good board scores are great, but not the end all be all alone. I want to see your clerkship scores. Letters of recommendations come a long way, and to me, I think it's helpful to if you can, to have done an IR elective month, because you're going to commit to IR as a career. And if you can have shown that you've done a month in IR, and again, I know not everyone on attending the webinar is going to have the opportunity, but I think that's another way to demonstrate an interest, and then potentially a letter from people who we know. We've always relied on that for the fellow applicants, and for a medical student, I think it's much harder to demonstrate that. But as Manoj said, the clear-cut thing is, I've been involved with the Medical Student Council for 3 years since I was an M1. I've done some research. Those are sort of the no-brainers. They've been interested in IR from day one, but that doesn't mean they're the only strong applicants. So it's going to be a lot of work for program directors to sift through these applicants. Sahar can speak a little bit more to that. He even alluded to there might be 200 some applicants, but not all of them are strongly interested in IR, and maybe he can key in on some of the things that he notices that differentiates a true interested applicant in IR versus those who just apply to it because it's cool. But I think we're looking for a lot of things, and for us, that's why we're going to interview quite a few of candidates, because we really want to know, and meeting someone is a hell of a lot more important to me than just what I see on paper.
Yeah, I agree with a lot of what was said. I've been a DR program director or associate director for the last 5-6 years, and I would say that we had a VR pathway, so we kind of looked at medical students looking into IR from the get-go, and a lot of people would apply to it and have an interest, but there's some who don't have interest and they just want to use a gunshot approach and apply to as many programs as possible and see what sticks. In general, some of the things that we look to see if somebody is really interested in IR, and Parag mentioned some of them, that you need to have at least one of the above. If all of them would be good, which are a rotation in IR at a 4-week. If you don't have it at the institution, get an away elective. There's a lot of options for that. A letter of recommendation from an IR, and some research in IR. An SIR member. If you're not an SIR member, and I don't like to use certain things as clear cut or something, but if somebody is not an SIR member, to me is somewhat of a red flag. Like, are you not interested, or you came late, or you're too lazy to do it, or whatever it is. So just do me a favor, whoever is there is attending now, just be an SIR member. It just goes such a long way. So attended the SIR meeting, been to any of the, because there's a lot of activities for that for students that were done even in earlier years. So all these activities that have IR in them, the more of these you have, the more I know that you're interested. Some people come to it late, and I have some of the best applicants who came to it. They've been involved in surgery, and that's what they wanted to do, or whatever, and then they came really late to it. At least have something, either a rotation or a letter or research or any of the things that I mentioned before. Concerning your general application, I would just don't have a sloppy application. Just pay attention to it. No typos in your personal statement, and pick your letter of recommendation writer as well. you may do a rotation with this big famous name, but, ask around if, will that person write me a good letter or not? Are they good letter writers? Are they going to submit it on time or not? If they're not going to submit it on time, some applications that are not full, some may not review them because they're missing 2 letters of recommendations, for example. So, ask around and know who can write good letters and make sure they're going to write you a good letter. Make sure they know you well, not someone who just saw you for 2 days and because they're a big name, they write you a letter. A more junior attending who is willing to write you a good letter, who knows you better, is much better than a bigger name that's going to write you a letter that is quarter of a page. So pick your letter right as well, and that tells something about you. That can you tell who knows you well to write your letter? So my recommendation is to have the 3 letters, one from a diagnostic radiologist, one from interventional radiologist, and one from a surgeon or internal medicine or any other clinical specialty. It doesn't have to be that way, but at least have one from IR, and then the 2 can be from or could be 2 from IR and then one from a clinical person. All of these can be worked out. It doesn't exactly have to be that way, but that's something I give advice to the students that advise. One other thing, have a good picture, and spend time taking a good picture. And if you're so sloppy on it, and if your picture doesn't tell who you are, and it's something that have to be presentable when you do it. And some people just look quickly at the application, and they don't have enough time to dive into every single aspect of it. So it's a simple thing sometimes, but trust me, every single part of the application can make a difference. And talk about yourself and your hobbies and interests. Don't just write biking, swimming, that. Just write about some stuff about yourself that makes it interesting. It's like, what, I would like to meet that person and talk to them about it. So in that hobbies and interests, write some, little bit narrative. Just talk about yourself so people, get some interest in and don't make stuff up because people will ask about that in the interview. So people want to meet students who think they can fit in the residency, and they try to find things in your application that makes you unique and interesting. So the more you have in there that talks about yourself, the better. And you can do that in the personal statement too.
I agree with all 3 of the panelists in terms of the primary qualities. I, as well as SAR, also look at being a member of SIR as a red flag, or not being a member of SIR as a red flag. We need to be devoted to the society that has pretty much paved the way for the IR residency and the different pathways for training. One other thing that I would like to note on is that don't downplay the diagnostic component of the IR residency, because I feel that a strong diagnostic radiologist makes a better interventional radiologist. All of us would like to do 100% IR down the road, and maybe that will be the case with the IR residency in the next 10 years. However, there will be a lot of jobs out there that will be 80-20, meaning 20% diagnostics. You may need to read. So we want to make sure that you are a strong diagnostic radiologist. So go ahead, and you don't have to really make a strong note of it in your application, but also be aware that diagnostic radiologists will also be looking at your application and interviewing it as well. So you will be spending 3 years in diagnostic radiology. It'll be the same as all of your diagnostic colleagues. So we want to make sure that you can pass your board. So that's where we look at the board scores, having strong ones there. So just make sure that, yes, you're really looking into IR, you have a sincere interest, you're a team player, you're hardworking, can work with different specialties. However, what sets us apart is our diagnostic capabilities as well. So don't downplay that because other diagnostic radiology attendings will be looking at you in terms of coming in as being part of their residency too.
Okay, thank you to you all. And our next question is based off the first question, so there may not be too much to add, but we can ask it. It's, what distinguishes a good applicant from a great applicant? And for this question, we can go in the order of Dr. Patel, Dr. Sabri, Dr. Rashon, and Dr. Kaja.
So some of this was touched on before. I mean, what we're looking for ideally is sustained interest in interventional radiology Can you hear me?
Yes.
Right. You know, so for the junior medical students who happen to be on this webinar, you know, the M4s, their application is in 2 weeks, and if they've just determined a month ago, it's going to be hard to take action on this. But I think if for the more junior medical students who've been able to can demonstrate an interest in interventional radiology that is sustained, they've tested it, that theory that, hey, this is a good fit for me. They've been involved in SIR, taken interest in projects, or volunteered to be involved in the Medical Student Council or other efforts within SIR. That really helps them demonstrate that they are making an informed decision. What I worry about is someone who just comes about interventional radiology very late in the game, sees it what it is at its surface, which is really intriguing, technology-driven, cutting-edge medicine, kind of at the bleeding edge, if you will, of where minimally invasive and/or the latest technologies are replacing, you know, older therapies, and sees that as intriguing, but hasn't really tested that by spending time in interventional radiology or being involved in it. That's hard because you don't know if ultimately it's the right fit. I think it's also hard for medical students to be able to demonstrate they have maybe the technical skills, but a lot of that can be trained. I think many of us feel like, you know, with time and the right training, we can get you there. But if you don't have the right mindset and the right understanding of what it takes, combining the imaging expertise that PJ has talked about, you know, that's the diagnostic component, with the commitment to the clinical care of these patients, and then being able to do the technical side of this. Yeah, I think that's what we're looking for, is that all-around great applicant, and I think it's hard to demonstrate that over the course of 3 months if you only came about IR 3 months ago. So to me, the great applicants are those who, you know, they happen to have great, solid board scores. Their clerkship rotations were strong to stellar. But they also had the opportunity to do some IR research potentially, or involvement in the Medical Student Council, demonstrated involvement and interest in IR from very early in medical school, at the very least in their maybe M2 or M3 year, and then did a rotation and got a letter from someone from that location, whether it's their home institution or otherwise, that corroborates the paper findings of strong scores. To me, that's a great applicant. That's a no-brainer for an interview, and then ultimately I need to see if I think that person's a good fit for our program, and can I work with them, you know, through 5 years, and they're trustworthy, and you know, I think the track record otherwise will speak for itself. You know, the interviews are tough because it's only 20-30 minutes maybe with an applicant, but you know, that's the thing that seals the deal after you get a strong applicant on paper.
I think more of the same. I would say that you know, you have to, you know, the dream candidate, or you know, everyone wants a resident who is strong academically and has a great personality and great to work with and is dedicated. So any way you can show all three will be great. So we talked about how to show you strong academically and you know, with all the, you know, with its scores. And again, the strongest not all and be all, but you know, if your scores are very high, that's a huge plus. You can, if your scores are not that high, you can always supplement it with high clerkship numbers and all. But if somebody, you can tell if their scores are high and the clerkship number, you know, records are pretty good and they have strong letters, you can tell that that person is very strong academically. And if they willing to work hard, they've done research, or they've done, you know, other volunteer activities, you can tell that that person is using their time efficiently. These are all great ways of knowing. And then personality, most of the time you can read through the letters and through the clerkship evaluations, and during the interview, we can tell a whole lot from the interview, what the residents you know, think of the candidate makes a huge difference. So dinners, lunches, you know, believe it or not, you're being interviewed all the time, although they tell you not. But in general speaking, you have to know that you're, you know, talking to everybody, and if you gel with everybody, and the residents like you, and the coordinator likes you, and you know, that makes a huge difference. So that's something to you know, we look at, of course, if this person is a good fit, you know, by everybody who was on that day, and you know, feel that they're a good fit. So these are things that we look for.
I'd like to talk a little bit more about the letters of recommendation. For the M3s and M4s, you probably already have your letters written already and all selected. but M1s through M3s, make sure that you choose someone who can write you a stellar letter of recommendation. Sometimes people who you have rotated with for a short period of time may not be able to write you a good letter. Ideally, you want to have someone vouch for you for your quality. Maybe you have something with your patient care abilities. One example that they can actually wrap the letter around and use that as a common theme during any of your rotations. I mean, it could be family medicine, someone who knows you really well, someone you've done research with who can actually account for how diligent you were and you were on time, you were punctual with getting assignments done. Those are things that we're looking for in an applicant, and it goes a long way, and it goes across the board from being a team player, good patient care, to being on top of a research project. So make sure that you pick really good letters, as Sarah was saying, maybe 2 IRs and 1 diagnostic, but you may want to go ahead and place another primary care or a vascular surgeon, interventional cardiologist, someone that has seen you work really well. And some of those clinical rotations that are similar to IR, they go hand in hand, and don't look at that really lightly. Really think about who you want to ask for a letter. It doesn't have to be the chair of a program, doesn't have to be a name, a big name. It needs to be someone who can really write you a letter so that we can sit down and really get to know you before you come to interview.
I think all the panelists have said most of the major points. I would say I would add that being in a leadership position is something that's great for your application, whether it's a volunteer organization or a SIR, AMA, ACR medical student group type, or an IR interest group. Even if you don't have IR at your institution, you can be involved with the student interest group. You can create a student interest group and get speakers from around the area. There's got to be some IRs nearby. I think any leadership position will help position you to be a great candidate, and it'll also help you learn more about the field and show you whether IR is the right thing for you or some other field. And so any leadership position, I think, really resonates on your application.
Okay, thanks to you all again. So our final question on this slide is there a certain aspect of the application process that you wish more students would know about? And for this, we can go in the order of Dr. Sabri, Dr. Rishon, Dr. Kaja, and then Dr. Patel.
I think I don't know if I wish they knew about that. Generally speaking, I would say the clerkship evaluations that the deans, they are in the dean's letter and they're submitted, and that's something that you just need to know that these are important. So your entire record is there, and you just need to be a good student throughout. So that's something to pay attention to. And volunteer, I think doing any volunteer activity, it's good to see that you're involved in your community, whether it's medical or non-medical. Any volunteer activity you do, and to show that you're a well-rounded person, I think that's something to show your personality is very important. I talked about the hobbies and interests and all that. We'd like to know more about you as a person. So, it's all the stuff that we talked about letters, recommendation, and the personal statement are important. But talk about yourself. It's okay. It's hard for people to talk about themselves and personal statement and all that stuff. I understand, but this is your chance to show who you are. And then at the interview, you try to show your personality and talk about different interests you have.
I would add by try to pick something that makes you stand out in a positive way. I know that through medical school, there are different stages that you want to focus on. Your board scores, just make sure that that's all you do whenever you're studying for your boards, and once you've done your best, then you can move on from that. Be consistent through your medical school career. Be a member of SIR, be an active member of SIR, and participate on webinars like these. also other things that go along throughout the year for medical student education and resident education. And just be an all-around a strong application. And just as Sarah said earlier, make sure that you proofread it, because once we see something that doesn't makes us know that you haven't proofread your application, have other people proofread it, it goes a long way. Make sure that it's really complete and you have no regrets once you submit it.
I think a lot of the important points have been touched on. I'll just add or reiterate, being a member of SIR, I think, goes without saying. If you're truly interested, most specialties have a society that they identify with, but some it's not as obvious. There's no question with interventional radiology that interventional radiologists identify themselves in training and in practice with the Society of Interventional Radiology. So being a member is a low threshold. It's free. It's very easy to do to become a member. If you're an M4 and you're not a member, you're going to be a member, and at least you can say that you're a member. But if you're an M1 through 3, be a member, and as PJ has just said, be involved. Show an evidence of involvement, whether you're on a committee and you volunteer some work, or get involved with some of the efforts that they have. It's all outlined very clearly on the website there. The other thing I'll say to the junior applicants, not so much the M4s at this stage, but at least you can take solace with this. We all have probably been involved with advising medical students, and if they're an M1 and M2, I let them know that, you know, obviously their focus now is their book work and the end goal of their step 1 scores, and do the best they can. The moment that they've taken the test, I tell them, don't look back. Your test is done. Hopefully you've done great, but if you haven't and you still have a commitment to IR, I'm not the type of program director that says unless you hit a certain number you have no shot. I said then you got to make all the other boxes hit right on, meaning you gotta nail your clerkships, which a lot of that is working hard. Obviously you need to have intelligence, but do all the things you can do. That say you're not interested in OBGYN, that doesn't mean you blow it off, and that's evident in a clerkship rotation that if you aren't interested in it, it'll show through. So consistency across the clerkships is important, because there's going to be parts of your IR residency where you're on a DR rotation where you may not have particular strong interest, but do you have the commitment to do it the right way through that period of time until you get to the next rotation. Those are little things, but they go a long way, and it's worth mentioning. So I'll just add that to all the other great points that were mentioned already.
I would reiterate some of those main points and add just a couple more. I think one thing that's very important is to have your application in within a reasonable time from when it opens in a couple weeks. I think many students don't realize that programs review the applications as they come in. Many programs do, and then as they are reviewed, interviews are offered. And we all would love to interview numerous candidates, but the problem is that there's a limited resources and time. And so I think it's important to have a complete, thorough, well-rounded application, but at the same time make sure you get it in on time and not miss out on getting an interview that you may have gotten just got beaten out by somebody else. And then again, as Sahar mentioned, is really concentrating on the pre-interview dinners, as well as talking with the residents at the programs. You want to make sure that it's a good fit for you and that you're a good fit with them. And so those residents are talking to you and telling you about their experiences, but they're also trying to find out a little bit about who you are and whether they can work with you in a dark room or in a procedure, on a clinical rotation over a course of 4, 5, 6 years. So keep that in mind.
Okay, thank you.
All right, so we have a few more questions about the competitive IR applicant. Thank you to the panelists so far for all the questions and advice you've been giving us. So the next question's, it's been brought up already a little bit, and it's what stands out in an application that students can do in their preclinical years and their clinical years, i.e. preclinical being first and second year, clinical years being third and fourth year. I know you all have talked about this already, so if you could briefly give us a summary of what you've been mentioning. We'll go in the order of Drs. Rashon, Kaja, Patel, and Sabri.
In terms of just splitting it up between preclinical and clinical years, you want to make sure and know what your institution has to offer in regards to interventional radiology. Look for your interest groups first and foremost. If they don't have one, go ahead and try to implement one and start one. You may want to start with your radiology interest group and see if you can go hand in hand or just start one on your own. In terms of the preclinical years, there are not a lot of clinical opportunities. I can speak for Colorado. We have what we call a clinical interlude where our second year medical students have an opportunity to spend some time in IR, about 3 days. So on that same note, see if you can shadow an interventional radiologist throughout your first and second year. Our medical students need to have a mentor throughout their 4 years. So you can maybe identify if you know early on that you want to do IR with a mentor and shadow that person periodically throughout your first 2 years. Another thing is if you have any other shadowing opportunity or rotations where you can do from an interventional radiology standpoint, go ahead and do that. In terms of your clinical years, we've tried to get the word out and start as many third-year rotations through a surgical block, through different institutions, through the student resident committee. We have subcommittees who are actually charged with that endeavor. Some of those particular rotations are on a lottery basis. If you have an opportunity to voice your interest in wanting to do a 1 or 2 week rotation, or if you have a full 6-week rotation on IR, go ahead and do that, because that's where those interventional radiologists at your institution can get to know you a little bit better, and you can get to know the specialty a little bit better as well. In your 4th year, visiting student away rotations is definitely needed. If you know the geographical location or a program that you're really interested in, try to get a rotation there. Pretty much any IR rotation would be paramount during your clinical years. And as everyone has said, make sure that you are trying to honor all of your clinical rotations, because that goes a long way in terms of how you will act and be as an IR. As an IR, we work with every single specialty on the planet. It's not any specialty that we don't deal with on a daily basis. We sit on family conferences. It's not just tumor boards we participate in. We sit and we give clinical information and our clinical judgment for patient care. So you want to make sure that you do well in all of your clinical years, but try to get as much IR exposure throughout and know the opportunities at your institution.
So I think we mentioned many of the points before and just reiterated. Again, during your preclinical years, you can be involved with volunteering and extracurricular activities, whether it's in medicine or not, whether it's an IR or not, just showing that you're involved and you go a little bit beyond your book work in your studies. It shows your character and involvement in whether it's the field or your community, but keeping in mind you want to really concentrate and do well on your boards as well as your classes. And during the clinical years, I think, again, being involved with research and doing well on rotations. I think the other thing would be involvement either with an IR symposium or starting an IR symposium or in your area or just participating in one. I think it's really important to help the other students as well as yourself. And so I think that there's been a lot of them popping up throughout the country, and being involved with that has been very, I think, beneficial to all of the students.
I don't have a whole lot to add. Yeah.
Go for it, SIR. I forgot which order we were in.
I was just going to say, I just was going to say I don't have to add. I'm going to leave it to Dr. Patel to finish.
I don't have much to add. I was going to take a slightly different tact, as opposed to what stands out in your application in and of itself, like, oh, I did this amount of work or I did this research project. I'd say in your preclinical years, find out for sure if this is the right fit for you. So if you're an M1 and you think you'd like IR and you're on this webinar, or your second year, spend time, shadow an IR, declare an interest in IR, speak to the interventional radiologist, whether they're involved in SIR, I'm sure they are in some form, at least as a member, or they have a training program, or maybe they don't. But at least you declare that interest. They will engage you more so because they know that you're an interested candidate, at least in your preclinical years. In your third or fourth year, spend time in IR in a meaningful way. Do a clerkship. We have an M3 clerkship at MCW. We also offer an M4 elective, and we offer a sub-internship. So those who have to complete, at least our local students can do their sub-internship in IR. But we also offer visiting students to do the same thing. I think it's a meaningful way to spend time in IR. You declare your interest from day one, introduce yourself, and get into the meat of it as much as you can as a fourth-year medical student. It'll show. It'll also inform your decision better, and it'll show through in your application, I think, in ways that are subtle, such as in your interview or through your personal statement, or ways you can speak to it more so and more in depth than someone who just read something off the website and is reciting that. So that's my recommendation. I think we've touched on a lot of this in various forms with a lot of the previous questions. So I want to leave some time for open questions too for you guys at the end. So we'll leave it at that.
All right, thank you so much. The next question that we had was in regards to, it's basically very, very similar. So for students interested in IR, what could they do during their medical school training to be better prepared for an IR residency, especially in regards to areas like research? For this order, we'll have Dr. Kaja, Patel, Sabri, and Rashon.
Great. So as has been mentioned before, I think being involved from M1, being involved in a webinar like this, many of the other RFS and MSC webinars are great to introduce you to IR. But also, I think it would be great to go to your local medical student symposium, be involved with the resident student interest group, and get introduced to faculty, residents, fellows in the field. I think it's also great for students when you're on your clinical rotations at the beginning of your third year. If you are on medicine or on surgery or any rotation for that matter, and a patient comes down to IR for any type of procedure, whether it's a central line or an aortic stent graft or an abscess drain, come and follow your patients. See it from your clinical team. If you can go down with your patient, it shows that you're dedicated to your patients. You'll get educated about IR without actually being on IR. A lot of times we have students who say, can they just watch from the room? And we say, go ahead and put some lead on and be scrubbed into a case, or just watch from outside. But it shows your interest, and it also shows your interest in your patient. And you can go back and report to your team if you're on medicine or surgery and say, hey, I had this patient today and they went down for an IR procedure. Here's what they did. The patient's doing great now. It shows you're really involved, and so it actually helps you on your rotation, and it sort of gives you a sense of what IR is like.
I forgot the order, so I'm going to go next.
Sahar, go ahead.
You keep cutting in front of me, Parag. You keep cutting in front of me, Parag. You need to know the order well.
I'm saying you're going to say such a good answer, you're answering for me.
Yes. Anyway, so I would say for, one of the best things to do to prepare before residency is to, as I mentioned, to take every clerkship seriously and spend enough time. In terms of what rotations to do, I would strongly encourage doing a vascular surgery rotation. I think it's a good way to get a sense of arterial access and scrubbing a lot of procedures and arterial and venous procedures, and it varies from each institution how much vascular surgery does, but I think it's a good one. It's a good one to do, and choose a good ICU rotation and be involved in that and to learn well, because that's something you're going to be doing more of in your residency. Definitely do a 4-week diagnostic radiology rotation. One of the important things to know is, do you like diagnostic radiology or not? If you absolutely hated your time as a medical student in diagnostic radiology, maybe IR is not the field for you. Although a lot of people, I've dealt with this a lot for a lot of students, and we have some residents who went into residency, diagnostic radiology residency, wanting to do IR, and they were absolutely miserable. They made it happen at the end, but now they join practices where you may not necessarily, as PJ mentioned, get a 100% IR job. So you'll be doing diagnostic radiology. So you need to invest enough time to see that do you like radiology or not, and do you enjoy it? Do you see yourself spending a good chunk of your time? The first 3 years, you're going to do a lot of diagnostic radiology. You're going to spend a lot of nights in the hospital doing diagnostic radiology call. And if you don't like it, if you're miserable doing it, you may want to think of others. I don't want to scare anybody away. I would want every single one of you to do IR, but I want you to be happy doing what you like to do. So maybe you can find other ways, to do what you like to do without going through radiology. But that's something just to keep in mind. Do at least 4 weeks in radiology, whether it's elective, whether it's a co-rotation, doing that. So and definitely do an IR rotation.
Okay. Would anyone else like to add anything else?
I can add something, Rebecca. Thank you. Just as Sarah said about just being happy with what you're doing, in regards to this question, areas like research, if you want to be involved in research, any type of research, let's particularly say IR, think about a question that you want to answer. Think about something that interests you. You want to be happy doing this because you're going to be in front of a computer, you're going to be looking at charts, you're going to be writing IRBs, and it's a learning process for everyone. And I would say that all 4 panelists, we are happy and we're lucky to be doing what we love to do. And we have our own niches in interventional radiology, and we're lucky to have that. So it makes it a little bit easier for us to do research because we like it. So whenever you pick your area of research, make sure that you complete it. Make sure it's an attainable goal. Set deadlines for yourself whenever you're doing your research project, and that goes a long way, because a finished project will go on your CV, and it's something that you can actually talk about in your interview, and it does stand on your application, as we noted before.
Okay. All right. Thank you so much.
Yes, thank you, guys. Our last 2 questions, these topics have been alluded to previously, but are a bit more focused. So the first question is, what are you looking for in a personal statement? For example, listing out the achievements, or talking about personal attributes, or rather discussion of interests in the field. And for this, we can go in the order of Dr. Patel, Dr. Sabri, Dr. Rashon, and then Dr. Kaja.
Okay, so as far as personal statements go, I don't think it needs to be, or nor should it be, a rehash of your CV or resume, or a listing of all the things that we can readily see that would otherwise, like where you went to college and medical school and such. That's all stuff we're going to quickly review. So that's not the point of the personal statement to me, and other people may have different opinions. I want to get a sense of the person and where the interest in IR came about. Can you get to that? And I think personal statements are hard. They're amongst the hardest things of your application to come up with, because you're writing about yourself, and we all have a hard time doing that, and doing that well, I think. But if I get a sense for a genuine interest in the field based out of an experience that you can speak about, to me, that's more telling than just rehashing what your CV says. So to me, that's what I look for. I do read personal statements. Everyone that comes for an interview will have had that personal statement read by just about everyone that's interviewing them. I look at every single application that comes through, and part of that evaluation is reading through these personal statements. And that's the kind of thing that I tend to look for. Things that will give me a little bit more sense about the person, and not the obvious things that are already listed on a CV or application.
All right, so some questions that I get asked a lot, and I'm sure you're going to have that as already asked by somebody, which is, do I write 2 personal statements or one? I'm going to apply for IR and DR. I'll just get that out of the way, that I encourage everybody to apply to both IR and DR. It's important. You can apply to the IR and DR at the same institution. It's okay. It's expected by most institutions that apply. It doesn't say that you're not interested in IR. It says that you're interested in the institution. So as far as I'm concerned, I look at it positively that you're applying to both IR and DR at my institution. And I think most programs will feel that way. For your personal statement, you can have the same personal statement for both applications, especially if you're applying it. It doesn't make sense to have two different personal statements, tell the two different stories. You have to be consistent in your message. There's nothing wrong with telling the diagnostic radiology program when you apply to them that you're interested in IR. And so you can mention, as Parag mentioned, says something personal, don't rehash your CV. Talk about why you were interested, what got you, some personal experience, a case, or what have you. And then talk about your interest in diagnostic radiology. Why do you think it matters? And because you have to also appeal to the diagnostic radiology audience there, the DR program director and the other faculty who are going to interview you. So, the personal statement should be safe. Don't go completely way out there. It can hurt you if you go completely out there. Try to be reasonable. Things that are about your life, your interests, and why you like this specialty, and anything interesting about your life that is not readily available in the CV. You can talk about some travels you've done internationally, what have you, and some volunteer work to kind of draw people to your application. I think that's fair.
All I can add to that is it's a personal statement, so tell your story. Don't tell someone else's story. Don't tell if you have family members who are in medicine. I mean, if it fits your story of how you got to IR, how you got to diagnostic radiology, then say it. Make sure that it's all about you, because we want to make sure that everything is consistent throughout your application, throughout your interview, and throughout the ranking process. So just tell your story, and that will mean the most.
I'll add one thing, and I don't know how everyone feels about this, but if there's a very large deficiency in your application, be it your scores or something on your dean's letter that you're aware of, I would consider discussing that briefly and addressing how you've overcome it or how you plan to overcome it, how it improved you, and you kind of twist it to you had a issue somewhere during medical school, and if it was there was a death in the family or there was extenuating circumstances, sort of discuss it, because we do look at applications closely, and we'll see that there was some blip in your record. If you have a great record, there will be a blip somewhere. So I think it's important to sort of mention that. It won't look like you're pointing it out. I think it's better for you to address it than somebody to find it and ask you on your interview, well, what happened on this day? And if you've sort of been forthright, I think it helps.
I agree.
Okay, thank you. And our final question here, along the same lines, what are you looking for in a letter of recommendation? For example, are you looking for clinical experience, or would you rather have a letter from a chair describing the accomplishments of the students? And for this, we can go in the order of Dr. Sabri. Yeah, please.
There you go. I predicted. I know some programs request a letter from the chair. I think some specialties request. I have no idea why. I can't believe a chair would write a good letter. They're going to be basically just rehashing your CV and asking people, because how well is the chair going to know you? So unless you've done research with that chair or something, I don't find it helpful, and it's not going to be a good letter. There are some chairs in some departments who are very involved, especially the chairs in IR, who are involved in the medical student education, who meets with all the interventional students going into interventional radiology, fine. But other than that, I don't see it as a way to help you. So I mentioned earlier, which specialties do I think you need to get letters from? Yeah, the chair, I don't get it.
I would also say make sure, I saw her and everyone mentioned before, somebody who knows you well, somebody you spent time with on a rotation or done an extracurricular, your research or volunteering, and they're in charge of that organization, or the faculty mentor. Those are the people who are going to really talk about you the best and not just rehash your CV, because we've all sort of been subject to that, where we don't know a student well and you want to say something good, but it sort of seems like a form letter. I would recommend to all the students also, when you are asking somebody for a letter of recommendation, is that you be prepared with a copy of your CV, maybe a draft of your personal statement and a cover letter. It sort of helps us, and sit down with that person for 10, 15 minutes if you have that time with them to say, you know, here are some of my goals. It really helps us personalize it and actually show that we know you and not just sort of just somebody who was on rotation. We spent 5 minutes with you and we're writing a form letter.
I agree with both of those comments.
Agree. You need someone who knows you. Don't just, I think the other thing I'll say is I think most people would, I don't know many people that would say no to writing a letter of recommendation. Another way to put that is if you ask someone, they'll probably write it for you, but if you ask them based on a name, a reputation, and not based on them having meaningful time with you, you're not going to get the same type of letter. We know how to look at letters. We know which ones are truly genuine and strong and which ones aren't. And additionally, within the world of IR, we know most of the people that might be writing letters for applicants. And even if we don't know them that well, there's little hesitation to pick up a phone and call. So I think make sure you do it with someone who you can at least feel like you have some meaningful experience with. I know that can be hard as a medical student. You know, you're not working with them closely like, say, resident applicants for a fellowship, but spend the time. Minaj made a good point, and I do this with a lot of people that I write letters with. I ask them, let's schedule a time. Let's review what you have. Give me a little packet of what represents you, and we sit and chat. I think that gives you a much more in-depth type of letter that you produced rather than just a yes, and then I'll look at your CV and rehash it for you in a letter.
Okay, thank you. Well, that's the conclusion of our set of questions. Thank you again, Dr. Rishon, Dr. Kaja, Dr. Sabri, and Dr. Patel. Now we will open the floor to questions from the audience. Just some quick instructions. Okay, so please type your questions into the provided chat box and send your questions directly to me, Mohammed Noor. When asking questions via the chat box, please indicate if you would like to direct the questions towards an individual or the entire panel. If you wish to ask questions to specific individuals but would rather contact them directly offline, please contact them via the shared contact information, and we will provide a link to their individual institutional profiles. So the floor is open now.
Mohammed, while we're waiting for questions, let me just reiterate, for those who are SIR members, remind them that you already are well aware of the SIR Connect, and those who aren't members, you should join. The SIR Connect's been a great forum for SIR members practicing interventional radiologists, but I think it's a great forum also for prospective applicants or those in the RFS to ask questions where a lot of common concerns can be addressed in a single forum and then can be reviewed. Some of the current M4s have already utilized this, and I think it's been effective because the same questions you have are many of the same questions that your colleagues around the country have.
Absolutely, thank you. So we are having some technical problems. If you do have a question, just go ahead and type it into the box because my name is not showing up in the chat drop-down box. So you can display your question publicly if you are comfortable. And while we are waiting to receive questions, there was an individual who emailed me a couple of questions, so I can start with that. Question number one: when will we find out what programs have been approved for the ESIR pathway? Will it be in January?
So a list of currently approved ESIR programs is available on the ACGME website. I think that list is also posted somewhere on the RFS website. There will be additional programs receiving approval in September. Is that correct, Sahar? The next meeting?
Yes, and I think we should. So now, so we should have the new programs in September. Like right now, the ones that were just approved, that they should be getting their letters. So these should be published soon, or the next week, right? This last group, and there's going to be another one in December. In December, so there's going to be another batch of programs going to be approved right before the interview season starts. And that's going to be a significant number. I forgot what it was, 30 new programs or something. So, and it's important to ask the program when you can always email the programs and ask them, the coordinator, and say, did you apply for ESIR? So that's something that, if you don't see their name showing up, to ask them if they applied for them. Most programs who apply for SIR will get it. They just need to make sure that they get the appropriate program requirements. But it's good to ask that question.
I think earlier someone mentioned that most integrated IR residency programs, those that are accredited for that, will likely offer ESIR, or they should. They certainly have the capabilities and the volume to support something like ESIR. The additional other diagnostic programs that do not have an IR residency that will offer ESIR tend to be smaller programs that actually have a meaningful IR experience they can give to their own DR residents, but maybe don't feel like they have enough to support a full IR residency. And those might be very strong ESIR programs as well. So the number of ESIR programs has to catch up yet, but expect the number to grow. The one other thing I will also mention is that the ESIR, there's a little bit of maybe a misunderstanding or confusion regarding this. We already touched on you don't match into an ESIR program. You match into a DR residency that may or may not have an approved ESIR track. The other thing is once you apply for that and receive selection, so to speak, within your residency for the ESIR track, then it's incumbent on yourself and the program director of the DR residency that you're at to verify that you actually completed the commitment of the ESIR track, which is 12 months of IR and IR-related rotations, a minimum of 500 procedures, but obviously 500 PICC lines or very basic venous access doesn't suffice. We've looked into this specifically. But the reason I mention this is that just because a program has the ability to offer you a meaningful variety of cases and 12 months doesn't guarantee that you're necessarily going to get that. And if you do not fulfill that 12 months and the 500 varied procedures, and then you go in and expect to get advanced placement in the second year of the independent residency, you may not be granted that. So the assumption is you will complete the ESIR, and that has to be verified by the program director from which you're graduating, where the ESIR is being performed. And I don't expect that to be a common problem, but I think on occasion this could occur. And so it needs to be clear to the applicants that you have to apply for ESIR, then you get selected, and then you have to fulfill it to be able to be eligible for the advanced year of placement.
Okay, so we got a couple of other questions. Firstly, does your program accept DO applicants with all the attributes you discussed previously? And I also got a question from an international medical graduate asking the same question.
Yes, and yeah.
Yes, our only requirement is that the applicants have to have taken the USMLE exam. So I don't know if the other programs have the same requirement for the DOs, because I know they have their own set of board exams. The other thing is that this can be state specific. So we do review international graduates, applicants that is, but our own state has a requirement to get state licensure, which is a requirement for you to start your residency, is that you've had to have had a certain number of years within an ACGME accredited residency prior to the start of your residency, or have graduated from a U.S. medical school. So they've made it hard at the state level for some international graduates to maybe be considered. Now they will have exceptions to this rule, but there's little things like that can preclude institution from institution.
I think the international students, so we, as Sarah mentioned, yes, we accept applicants from DO, and as Parag mentioned, we would also prefer that they take the USMLE so that there's an apples-to-apples sort of comparison with other students, and it's something that we would understand better. In terms of international students, I think that that is usually handled on a GME level from the institution as well, and so that has to be approved by the GME, and it's not necessarily program dependent, but it's institutional dependent in terms of visas and support for that. I would just reach out to programs directly and ask them.
University of Colorado considers both, but we have the same stipulations as Manoj and Parag alluded to.
Okay, perfect. Next question, is there a hard cutoff for step 1 scores? For example, 230?
We are, since our applicants are going through similar process as our diagnostics, a little bit different for IR, but all programs need to have or set up some type of cutoff because it'll just be too many applications to review. And we know that a lot of people have very strong applications, but in order for program directors and committees to make sure that everything is reasonable, there is a cutoff. Every program has a different cutoff, though, for boards. Not going to say anything more than that, but you want to make sure that you have a competitive board score, and you know what competitive is out there at this particular time. And what was competitive 10 years ago may not be competitive now. So if you want to have a competitive application, really supplement it with other things, as we said, with research, with leadership opportunities. But for those M1s and M2s who are on the webinar, whenever you are preparing for your boards, make sure that the time that you have studying for your boards and working up to that point is dedicated to that. And I talk to a lot of my medical student mentees throughout the year that whenever that time comes, whatever leadership responsibility you have, whatever other responsibility you have, and I'll say this out there, put it out there, with family, you just really have to focus on your boards because that's your one shot that you can actually do the best that you can. And once you're done with your boards, you will have no regrets that you've put in every ounce of time and effort in preparing for them. That's a long-winded answer with not giving you the cutoff, but every year our applications and board scores become higher and higher. So we want to make sure that we interview the amount that we can with the resources that we have.
This is definitely the favorite question. Every time we have this set up, and I'm so glad PJ answered it well. You know what's competitive. Work hard on doing it. I just add one more thing is, do not be discouraged if you get one score that is not competitive. Work hard on the other steps. You do step 1, then work hard on step 2 to get your score higher. We've had a lot of success stories when the step 1 score was not what was desired, not consistent with your track record in your clerkships, and then step 2 is more representative. We'll ignore step 1 score and look at step 2. But if both step 1 and step 2 are not competitive and your clerkship scores are not that great, that is an issue. But if you have good clerkship scores, one score is not that high, the other one is good, then we know that, yeah, you just had a bad day. So don't be discouraged if you have a better one.
Okay, I've gotten several of the similar questions. How will interviewing work if a student applies to both IR and DR at the same institution?
So I don't mind taking that one. So at our institution, all applicants who apply and are going to be interviewed for IR are interviewed by IR and the DR as well as surgery all on the same day. And so if you are granted an interview for IR, you will automatically be interviewing for DR as well. So you will have the opportunity to interview for IR, and the DR program, and then surgery as well. And so keep in mind, you're going to interview with a few interventional radiologists. You're going to interview with a few diagnostic radiologists because it's a combined program. And so that will be there. And just to be sure, when you apply on ARS, that I would click both the DR and the IR residency if they have it at the institution.
Yeah, I'll add that. So they are distinct program numbers, so they are separate. So you do have to apply to both separately. I think that goes without saying, but it's just worth reminding you that you can't just apply to IR and then show up and assume you're applying or interviewing for the DR program as well, because in theory the DR program has not even reviewed your application yet because you haven't technically applied to them, so they don't see you on ARS. So do click both buttons if you're considering doing that. I would highly suggest it. Our program, similar to University of Michigan, is planning on combining our interview days for those candidates who want to do the IR residency but also be interviewed for the DR residency, so it would all be done on the same day. We're designating days for interviews for IR candidates that allows them to interview with the DR program the first part of the morning, and then IR for the second half of the day.
We're in the process of, I'm sorry, go ahead.
No, you go.
Okay, thank you. We're in the process of looking at extra days. We are, since our first year going through the match for our integrated pathway, we want to make sure that we give the applicants a representation of IR. Most of our DR interviews, or all of our DR interview days, are on weekends. So we want to make sure that applicants who are applying and interviewing for an IR spot have the opportunity to see what a normal work day is for us and know how the workflow goes, similar to how we do with our fellowship interviews. We have less diagnostic days for interviews than we will have for IR. We will try to coordinate as many of those dates with our diagnostic dates to make it convenient for applicants who are applying to both, because we do understand that it's costly with travel and hotels, but we will not have that coordinated with all of our DR interviews. So applicants may need to come back for the IR residency interview.
We have them combined. Usually we've done that for years. It's on the same day, but the ones who are interested in IR will also meet with the IR program director and some IR faculty and get a tour of the IR section and such. And we'll also meet with the prelim surgery because it's a part of a categorical. So that's, we'll try to kind of save a trip. In general, expect you will apply to some programs in their IR and DR, and you'll get a letter saying you're interviewed for, you have an invitation to that you're going to be interviewed for IR or DR or both. So there is a chance you may apply to a program's IR and DR and only get interviewed for DR because the program don't think that you met a certain qualification for IR. So it's always good to ask that question. It's like, and confirm that am I being interviewed for which of the residencies. But don't be surprised that you may get, you may not make the cutoff for one and make the cutoff for the other. So not the fact that you applied doesn't mean that you're going to be interviewed for both.
Okay. Thank you. Next, most frequent question, Step 2 CK scores. Do you require a Step 2 CK score? If not, is not having a score looked at as a negative aspect on the application?
I can answer that quickly. I would just say it's good to have it. It's good to know that you're going to sit for it. Don't do it after the interview season is over. It's good to, you know, if a program may ask you, are you planning on doing it? If you say, yeah, I'm going to do it after the interview, it's not great. I would like to know that you're going to do it. Especially, I want to know that you passed Step 2 CK before we're going to rank you. It has happened in the past in other programs that I've seen that somebody didn't pass step 2 for internship and they couldn't show up because they didn't have, it's just a mess. So I would like to know that you passed your exams before we rank you.
Okay, perfect. One of the other frequently asked questions, when will the earliest interviews be sent out?
SIR-RFS opens September 15th.
Michigan started reviewing already, I think.
Yeah, they already know who they got. I think it's, September 15th, we'll get a flood of applications. The most diligent program directors will try to review as many of them as they can in that first 1 to 2 weeks. We're tentatively looking at interviewing candidates as soon as the first or second week of October. It just depends
My
on
God, man, you're killing us. Seriously? That's too early.
We're not the only ones, Sahar.
I know these Midwest, I know, because the weather, they want to get them before snow starts, November 1st till March 1st.
There's no flights to Charlottesville anyways, don't worry.
That's fine. There's a lot of good ways to get there. I'll pick you up personally. No, one important thing is Dean's letters are released October 1st. So, for most programs. So it's so hard to get all the judgment before October 1st. I don't review applications before October 1st. I just, first week of October was when I review them, and we start interviewing last week in October. Usually we do 1 interview day in October, and then the bulk happens afterwards. So there's an issue with interviewing that early, is just the dean's letters and being able to send interviews after these letters are out. So I don't know that people are interviewing that early. That's why I'm telling the students who are on here and tell everybody that get your application ready soon, because the problem is once the applications are filled, once the spots are filled, even if you're a very good candidate, there may not be enough spots in that particular place you want to go to. But you always can wait list, and in January there are a lot of cancellations. People overextend themselves. They schedule so many interviews, and when they come to January, everyone is tired, and you start getting some cancellations, and you run out of money and energy and all this stuff, and they'll be opening. So if you like a place, you want to be at a place, but they can have you, don't take it personally that they don't like you because your application is not good. It has to be waitlisted, and then keep an open mind to get back in there. It was just didn't happen a lot of times because there's no spots, and the application came in late, some letters were late, the dean's letter was not released till late, and so on. So,
as Sahar mentioned, we as Parag mentioned, we interview in Michigan in the mid-October range and continue until January and February. So it is good to have your application in early and have a complete application with the dean's letter expected on October 1st.
And our interviews will start late October.
Okay, perfect. Next question, will the programs that will be approved in September, will they be available for this year's ERS application?
Yes.
Yes.
Okay, perfect.
just to quickly, also some West Coast programs won't send their invites till really late. So again, don't be discouraged by that. It just depending where they are, most West Coast programs don't send invites till way in October, and they don't interview till November and later. So.
Okay.
Okay, let me see. Another question that is really common is in regards to the intern year. Could the panelists please highlight more about the internship year, especially programs that don't have that built-in internship? Essentially, is there a preference for students to do IM, general surgery, or transitional year at your institutions or in general?
I would say this is a...
Go ahead,
Parag.
We can.
Okay.
I think we all have some comments on this, so go ahead.
Okay. this question has come up before, and the trend has changed. I personally did an internal medicine internship, but the majority of consults and patient care that IR is doing is via some surgical service. And you really get the management skills that you need, similar to interventional radiology, by doing a surgical internship. Now, all in all, there'll be different types of internships, some that you may not be getting into the OR. You'll be just managing patients on the floor, but that in itself is really important. You should be looking into programs that may require you to get into the ICU, which is one of the only requirements that we have in the IR residency during those clinical years. So it's important. I would say, for the most part, choose a surgical internship. You could learn other things in internal medicine, but I think surgery is the way to go with where we're headed with the IR residency.
So I think I'll give you a short answer first, and then some what I think you need to guide your decision on. I think all things being equal, I think surgical prelim years are probably going to offer you the most well-rounded clinical training, most akin to the type that will be useful for you as an IR in the future, as well as the opportunity to give you some small technical or procedural component to it, followed by maybe an internal medicine prelim year, and then transitional year. But I will say a caveat: there are bad surgical prelim years, and there are excellent medicine and/or transitional years out there. Not uniformly all of them, but what you're looking for is something that's going to give you a strong clinical foundation. This intern year, clinical year, is way more important to the IR resident than maybe it is to the DR resident. While it's a requirement for the DR residency and they have to gain some clinical skills, this is the foundation upon which your training after that in the IR residency will build upon, right? So you need to have a strong ability to be able to care for patients, because guess what? You're going to be a DR resident for 3 years, roughly, after your clinical intern year. You may have some clinical months interspersed within that 3 years, and then you're going to be a PGY 5 and 6, and you're going to be back to taking care of patients. Now, I'm not going to say you're going to remember everything from that intern year, but if it was a very poor experience and you didn't have much there, you're going to have less to call back on or fall back on from that experience. So I think you really need to choose wisely, and you know, we can't guarantee where you're going to be aside from programs that have it tied into it. Our surgical prelim year was at one point to be tied to our residency. Because of funding issues, we couldn't promise that, but we highly encourage it, and they're willing to craft it to rotations we think are important. But I think across the board, surgical prelim years tend to be more like the type of training that we want, good ones that is, that will support the IR residency in the future, that experience at least.
I agree with that. You know, our surgical prelim year is tied into it, but on a personal note, I did a transitional year, and I think what you put into your intern year, you're going to get out. And so if you look at a transitional year that is sort of intense, or an intern year where you can have electives and you can sort of craft it to what you want to get out of it. I know personally, I did a transitional year, but I had 3 months of elective where I actually did a couple months of surgery as part of it, and so I was able, in ICU, and so I was able to get out of it more than I guess going to the golf course, for example. So you want to just put in a lot to it, and so look for a program that fits for you. But if I had a preference, I would select surgery.
I agree with what was said, especially the last point that Minhaj mentioned. There's some good transitional years where you can do a lot of work and tailor it that will be more beneficial to some surgery internship year. You'd end up doing some breast surgery and thyroid, which is not going to be helpful for you. But in transitional year, you may tailor it more, do a little more radiology and some more ICU or stuff that would be helpful. But in general, surgery tends to be better. I think we all agree that telemedicine will be the least. But you know, I would say you can still rank. When you rank the transitional years, you can change the ranking depending on the attached program you're going to. So I would encourage you to try to be It's best if you can do it in transitional year or the prelim surgery year in the same institution that you're doing your IR residency. Tie that ranking to it, because you'll get to know people better. They know you. You have these relationships. You'll help your IR team a lot if you know the surgery residents and the other medicine residents and what have you. It makes a huge difference. So that's something you can plan if it's not already part of the program.
Yeah, I think that's an important point, Sahar. I think we've had residents come through the DR residency who've stayed on to do fellowships, and they did their intern year at our institution. And there's a huge difference in the relationships they have with many of our referring colleagues who we know well, but they've been with for a history of 5 years, so to speak, prior to their meaningful time in IR. So, like I said, there are programs that have the prelim year attached to it, but there are going to be programs that offer prelim years at their institutions not necessarily attached. Now, I know that it potentially means an additional interview, but if you have an interest in advance, you could reach out to the program directors and see if they could arrange for something to accommodate you during your visit if that's you have of interest. I don't think it hurts to ask, at least.
Okay, thank you. This next question is directed to you, Dr. Kaja. A student asked, you mentioned a surgery prelim year is linked to the integrated program. Will we need to apply to this separately on EROS since the integrated IR program is not listed as categorical?
Yes. So the difference is sort of semantics, but it is a linked program, and in order to match at Michigan for the IR residency, you would match it. You would automatically match at the surgical prelim year, but because they're not, it's not a categorical program. It's a linked advanced program. So that means that they're together, but somewhat separate. You have to be able to click on it on ARS so that the surgical program can rank you, and we coordinate and discuss with surgical teams to make our rank list.
Okay, thank you.
We make it very simple for you. You can just do categorical program and have surgery attached to it. UVA, that would be.
Okay, so just to reiterate for the students, UVA has a categorical program and Michigan has a linked program where you do receive an acceptance to both surgery and IR.
Yes.
Okay, perfect. Okay, one other question. What are the particular training focuses at your respective institutions? I think that's to mean, do you guys have clinics, or is it more of a vascular or oncology focused practice?
I can start off.
Well, I think for all of us, we all have clinics. To have an IR residency, you have to have clinics. You have to have a clinical focus. You cannot have an accredited IR residency unless you have a meaningful clinical experience. It's a mandatory requirement. It will be looked back in reviews of the programs, and continued accreditation will be incumbent on having and demonstrating a meaningful clinic. So you shouldn't have technically any concerns for that. It's a reasonable question to ask about the clinic experience as a resident going through, but the actual presence of a clinic, if you're applying to an accredited IR residency, they have had to have demonstrated they have that to even receive accreditation.
I totally agree with what Parag said. In terms of some trending things, I would have to say that each institution that has an integrated pathway will be a little different in what IR-like or IR-related clinical rotations they will actually offer. It all depends upon the local politics at that particular institution and the collaboration and collegiality that they have with different services. I would have to say that one thing that's trending with us and maybe other institutions is that there are more and more programs, fellowships, you name it, that are asking for their trainees to maybe have some time in IR since they are going to IR a lot. So there's some reciprocity that we're finding there. So if we're going to train their resident or fellow or have them do a rotation with us, we in turn will likely have a rotation with those particular specialties too. And they're usually specialties that we have multidisciplinary tumor boards, vascular conferences, other things, other research collaborations that we have with these particular faculty members. So those are some things that we see that are going to be trending, because we work with pretty much every specialty, but most programs will want to make sure that they're well-rounded, that they give you enough vascular experience, they give you enough oncology experience, hepatobiliary, and wherever they're lacking in that, they hopefully will have those IR-like rotations on those clinical services that you can get that experience.
We have a rotation established with vascular surgery, and we have some in the second year. We have an ICU rotation early on, and we have another one later on in the last year, and have a rotation, a clinic rotation where you spend time in hepatology, vascular medicine, and IR clinic in the senior year, as well as dedicated research month. And there's a clinic every Thursday that's staffed by the IR residents. Every program you're going to see has some sort of a IR-related rotations that they have built in. The ICU is a must. Everyone should have clinics, and you're going to have a smattering of, vascular surgery, oncology, hepatology, and such. So you're going to hear that, and that's something you're going to go and ask every program in detail about exactly what they have. But that's just a sample of what it is, and every program is going to have locally what they think is best from their perspective.
I agree with Sahar. We have very similar types of rotations with ICU, vascular surgery, hepatology. Transplant surgery is another one that some programs have, as well as anesthesia and pain medicine. We also have a selective type of rotation where the residents can select one of many different options, which may be something they're focusing on during their PGY5 or 6 year. I also think all of the program directors here, their programs are very well-rounded. I think you want to make sure you look for programs that have a breadth of types of pathology and patients, whether they have a VA, a children's hospital, a university hospital. I think everyone sort of has something similar to that, and has rotations if they're missing something to fill in those gaps.
Yeah, so for us, we have a vascular surgery rotation elective. For those who do a surgical prelim year here, even though it's not technically linked, they've agreed to include anywhere from 1 to 3 months of vascular surgery, surgical oncology, transplant surgery, and areas of focus outside of just about 2 or 3 months towards what we think is IR-related experiences. And then during the IR residency, we have a palliative care rotation, vascular surgery, and then options within oncology and hepatology, among others. So, and we get a wide experience, like I think all of the panelists here, with regards to vascular and oncologic procedures.
Don't you have also wilderness medicine, in your thing?
We're in an urban environment.
That's Colorado.
More so than Charlottesville. Yes, exactly.
Thank you so much. This question is more it's actually for residents. I wanted to know, what is the pathway for current first-year radiology residents? Which programs offer the independent pathway, and is it offered through NRMP? So
there are no currently accredited independent programs, but programs can begin applying now. And so I think many of the panelists here will be beginning that process. I suspect. I know we are. And current first-year residents, to answer the first part of your question, have a couple options. They can either see if their DR program that they're currently matched into has an ESIR and apply to that. If it does not have an ESIR, I would urge them to speak to their DR program directors and express their interest in IR, and urge them to apply if they have the abilities to support an ESIR, because that's in their best interest. The candidate's best interest and the program's best interest for other prospective candidates. And then they can apply, and independent programs will come about as soon as January of 2017. We will hear of the first group of independent programs, and then again in the spring. but the programs really won't begin until July 1st of 2020 with a match through the NRMP, March, I don't know exactly the time frame, but it'll be in 2018 match, 2018, 2019 for the year ahead, similar to what the fellowships are currently, where we match a year in advance is the expected process, but it will be through the NRMP.
And the other option for the first-year resident is, if that program has an integrated residency, is to do an internal transfer, like Minhaj mentioned. They did in Michigan, some residents who can internally transfer into their residency once it's approved.
Okay, thank you so much. All right, so we're nearing that 10 o'clock mark, and in the interest of time, we will just have one last question. So the question is, if we don't match into the IR in our desired application cycle, what do program directors recommend we do in our time off to improve our standing as applicants?
Match into a DR program. I encourage you to not limit yourself to IR programs only and think that IR integrated is the only way for you to go. That's personal. I mean, you may hear different opinions from your advisors and such, but I say that get into an IR residency if you can't, and if that's your desire, get into a DR residency at a good program that has ESIR. Even if the program doesn't have ESIR, you can finish your DR residency and then do a 2-year independent residency, which is good training. You're going to get 2 years at a good institution that is accredited to get training. So even if you don't get ESIR, it's not the end of the world. I mean, how we all train, everybody here except for Minhaj, who went through a direct pathway, the rest of us basically did a residency and a 1-year fellowship. So it's 2-year fellowship, not the end of the world. So get into a DR residency and then do 2 years of independent, and it's 1 extra year of training, and you got your dream of being an IR. So yeah, I would not consider ranking only in a grade IR and then spending a year doing something, the fact that you didn't match. So anyway, so that's something that I would encourage you to do.
I strongly agree.
Yeah, exactly. There will be, let's say you get into a diagnostic program, and that institution may actually start up an IR residency program within the next couple of years. So you may be that transfer into the IR residency program. So there are a lot of things a lot of pathways out there for you to be an IR. So you want to use as many options as possible and really go for everything that you have. If you want to be an IR, then you're going to use every particular option available to you. Before we finish the call, I just want to make a note that the SIR staff will be sending out a survey to all medical student SIR members to survey, asking about, well, what particular things will you be looking into applying to IR integrated versus ESIR, those particular questions. It'll be a short survey, and it's going to help direct program directors outside of this webinar of getting ready for you guys. It's important for us to make sure that we have the appropriate amount of spots available and pathways available for all of you to become an interventional radiologist, and that's going to be an important start.
Okay, great. Thank you so much for taking the time out of your day to do this webinar. So at this time,
so this is the end of the webinar, and we would like to thank the program directors for taking the time out of their busy schedules to answer questions. And
we also, sorry, Mohammed, you can go ahead.
Also, we would like to thank our residents, Alex Joe, Andy Nightcamp, Akel Ketapal, for assisting us during this webinar tonight. And back to you, Rebecca.
We'd also like to thank all of you all, everyone, for attending the webinar, and we hope this information has been helpful. If you would like to access this webinar again, we will be sending an email out in about a week with information to access the webinar that you have been in part of tonight. And once again, I'd love to thank the program directors, again, Dr. Patel, Rashon, Sabri, and Kaja. Thank you so much for spending time and answering our questions, especially during application season.
No problem. Good luck.
Thank you, guys.
Yes, absolutely. Thank you. And sorry to those whose questions did not get announced. There were about 100. We tried to pick the most general questions, so it would be best for everybody listening in. But I've attached
we can do
the
another one.
websites. Absolutely.
Next week.
So we've attached the websites to the institutional profiles of our kind panelists, and you guys can go ahead and get their contact information then, if that is okay with you guys.
Absolutely.
Yep.
That's fine.
Sure.
Awesome. Well, thank you again.
Thanks. Good night, guys.
All right. Thanks so much. Have a good night, everyone.